Welcome to the Doctors Hospital Distinguished Lecture Series. Every month we invite members of our medical community to speak on topics that matter to you, the Bahamian public. We trust that you will find this information useful. Now sit back, listen, and learn. Isn't your health worth it?
Good evening, everyone. Okay, so I'm a bit under the weather, so please excuse me if I start coughing and take a break in between. It's good to have you all here, and I would like to walk you through this pretty complicated topic in the sense because I'm pretty sure very little awareness exists with regards imaging and obviously about advanced imaging in the general domain. And I want to try and keep it simple, though you might find a lot of literature being exposed here on the slides. It's because for others who look at the slides can read through it in their own time, but obviously I'm not going to dwell deep into them when I talk. So the topic is coronary CT angiography, okay? In short, CCTA. I'm going to divide this talk into these main groups. Obviously, we'll first discuss what is coronary, what is CT, and what is angiography, so that we get the basics of the exam. And then I'll walk you through some indications, the procedure itself, the risks associated, how the results are interpreted, and if there are any limitations, what they are. Okay? So this is the general overview, and obviously after this I'll walk you through some images, good looking stuff, to impress upon you how relevant this exam is in the context of evaluating the coronary arteries. So to kick off, coronary arteries, the first component. So the coronary arteries essentially are the blood vessels which supply the heart. Okay, so the heart, from the day we are born, or I probably go back from the day we are conceived, 4 weeks to say, till the time we die, the heart is beating insistently, consistently, persistently without stopping, right? And it receives very important blood supply throughout by the coronary arteries. So which is the pipeline to this important lifeline. If the coronaries get blocked due to any cause during the course of this life, then it has great implications on the heart itself, and thereafter it affects the morbidity and mortality scenario for an individual as well as for a community. So coronary arteries can be obviously affected through congenital birth defects, which is from the time you are born. It's inherent, it's genetic, or it could be acquired. We'll come to the risk factors which lead to acquired coronary disease. So essentially, the block in the coronary arteries which supply the heart leads to angina, commonly known as a heart attack, right? And it is a major cause of both morbidity and mortality, in the sense sickness and death, with enormous costs to individuals and to the community and to the population, right? Coronary arteries, for example, because we're talking about coronary, I'm just going to show you an image of anatomy. So this is the root of the aorta. Aorta is the biggest vessel in your body, which is the artery. And this artery gives off certain vessels, branches, which are called the coronary arteries. So this here is the right coronary artery, which is coming off the aorta. This here is called the left main, which is coming off the aorta, which branches into the left anterior descending and circumflex. So these three, the RCA, the LAD, and the LCX, are essentially the main feeding arteries or main coronary arteries which are supplying the heart. Just to give you an overview of the normal anatomy. Coming next to CT. So we're talking about CCTA, right? So coronary was the first component. CT. CT stands for computed tomography. It is now obviously a mainstay of imaging. Almost all departments tend to have CT. We are fortunate in our department to have one of fairly advanced machines. It's a 128 slice multi-detector CT. 128 is a number which refers to the number of sections it can take within one rotation, okay? And that is a big number. I would say 30 years ago, when in the 70s or 80s, when CTs initially started, there were single slice rotations, one slice per rotation. And we have moved to 128. Actually, there's even a 320 slice CT in the market. But for all practical purposes, 128 is very, very good. The non-invasive visualization. So we'll come to what is non-invasive. The non-invasive visualization of the coronary arteries is very difficult, okay? Because the heart is constantly beating and these vessels are very small. They are tortuous, they are small, and they are in motion. So if for us to be able to see these small vessels, and that too without actually putting a catheter in, and we'll come to that as well, it demands a machine which is able to do this very fast and very precise. Okay, so that's called as temporal and spatial resolution. Temporal resolution means its ability to resolve things in very short intervals of time. So this machine can actually do temporal resolutions of up to 100 milliseconds. That's very short interval of time. And spatial resolution means the smallest distance to which it can precisely demonstrate anatomy. And for this machine, it is around 0.04. Okay, so that's like a very small. It's quarter of a millimeter. It's really small. And that too in 3 dimensions. It's not just about you need one dimension. Its ability to do that in all 3 planes. So, and we'll come to when I show you the images as to how that is important. For all who have been in a CT scan, this looks very familiar. But those who haven't been, a CT is like this. Essentially, there's a donut here, which is called the rotating gantry. And then there's a table here, which moves. The patient lies down on this moving table. So the gantry is composed of an X-ray source, which I've just marked here as an X, for example, which showers these X-rays at precise intervals in the form of a cone beam. And that falls on this array of detectors, and they are very sensitive detectors. So the patient moves inside at a constant speed, and this X-ray source with the detectors move around the patient, sending out beams at constant interval. As it does this, it acquires a volume of data, and obviously it's processed by very advanced computers. The software's technology itself has also evolved into now what we call as iterative reconstruction, which is able to take out information which was previously not possible. So that post-processing allows it to get this volumetric data, which can allow us to then see these very small vessels. The third component of the CCTA, so I spoke about what the coronaries are, the arteries which supply the heart, the CT scan, which is the computer tomography, a very advanced machine, and third component is angiogram. So what is an angiogram? Angiogram refers to the visualization of an artery by putting contrast into it. So it's a generic term. It can be done in many different ways. So to show it to you here, this picture, this is an artery. In normal scenarios, an artery actually has blood, and it's not going to be seen any different from other tissues. For us to be able to see the artery different from adjacent tissues and to be able to delineate it, we need to fill it with something. And that filler is the contrast or the dye. It's usually iodine-based. What we use is called Ultravis 370. This dye is injected in a peripheral vein at a very fast rate. Okay? The machine then tracks that dye, and once it reaches the optimal density or a high contrast density, it triggers the scan. And the scan happens very fast. Okay? All this is done coherent or simultaneous with the ECG recording of the heart. So that ECG recording allows us to take the images when the heart is at its slowest, when the motion is at its slowest. Because when the motion is fast, then we'll get artifacts. So I'm not going to go into that because it's obviously far beyond the reach of this discussion, but an ECG actually can differentiate the diastolic and the systolic component. And most of the imaging is done in the diastolic component when the heart is relaxed. Also, we may administer some beta blockers, which are drugs to slow the heart. We may also introduce some sublingual nitroglycerin to dilate the arteries. Not necessary, depending on the requirement of the case, we may do these additional drugs to improve the visualization of the arteries. So, angiogram, right? So, I just put the slide in here, which is to differentiate the catheter angiography from the coronary angiography. Unfortunately, this has moved on to it. So, catheter angiography here on your left-hand side of the screen, which is done under an X-ray machine as well, but it is biplanar or C-arm or a fluoroscopy. It's different from a CT. In this, the contrast is injected directly into the root of the vessel and you see it. Okay, so a catheter goes all the way there and it is injected. As opposed to a CT angio where the contrast is injected in a peripheral vein in the arm and not via a catheter into the root of the vessel. So there's a big difference there. Many times, non-diagnostic findings on stress tests lead to a physician asking for an angiogram. And the angiography can be catheter or CTA. One of the reasons why CTA or CCTA has taken up is because 50% or more of patients who are referred for an elective coronary angiogram are found to not have significant coronary artery disease. So it's important to know that a lot of times when patient is scheduled for a catheter angio, 50% of the times there is not significant disease, which means that an invasive procedure, which entails its own set of risks, admission, anesthesia, overnight stay, is being done for no findings. And that's where the screening tool, which is non-invasive, becomes important. The test itself is not just limited to the coronaries. The test also evaluates the calcium burden in the coronary arteries, what we call as calcium scoring. Obviously, it evaluates the coronaries. We can also do a functional assessment of the heart. We can see the heart beating. We can evaluate the valves, the wall, motion. We can even see actually microperfusion of the myocardium. And it's much more holistic in the evaluation of the heart. We can also evaluate incidental findings outside of the heart, the pericardium, the mediastinum, the lungs, the bones, such as lung nodules and hiatus hernia. And when I show you some pictures, I'll be able to show that to you better. So we covered coronary, CT, and angiogram, so you get the basic or the understanding of what exactly a CCTA means. Coming now to what the exam itself is, okay? Indications. The indications now are something which are always labile and they are actually in flux. I'll come down to why I say that. This group here is a definite or a proven or a recommended acceptable group, the symptomatic group. If a patient has chest pain or breathlessness, but a physician is not convinced of coronary artery disease, so there's atypicality to the presentation. Something is not matching. It is not really proving that this patient has chest pain due to coronary artery disease. Atypical. Syndrome X. There's no reason for this patient to have a chest pain which is coronary. Suspected myopathies, anomalies, post-bypass, post-stenting, tumors, inadequate echos, inadequate stress tests, or indeterminate stress tests, and congenital heart disease. So this entire group of patients with atypical chest pains and symptomatic group of patients are recommended to have coronary CT angio, but with limitations, and I'll come to that. I put this in red here, the asymptomatic group, because this is the group which is in flux. There are people who support this, the people who don't support it, and the guidelines actually do change over time. Asymptomatic means that you have no complaints related to your heart, okay? And you want to have a screening test, but it entails radiation. So now there's a risk-benefit scenario which needs to be judged. And that's where it becomes a bit of a flux. However, if there are significant risk factors, and if you look at this list, having a family history of heart disease, high triglycerides, history of smoking, diabetes mellitus, ECG abnormalities, stress test which is equivocal, hypertension which is there for a long duration, and non-coronary heart surgeries for adults. So this entire group, there are certain combinations of risk factors which even in an asymptomatic individual can push the physician to ask for a CCTA, okay? This, however, this has many things written on it, but this, however, is a recommendation of the American College of Cardiology in 2012, which kind of says that it should not be used to screen patients who have no signs or symptoms of CAD. But it also says that if there are two groups which you want to say no to, then those are the extremely low risk and the extremely high risk. So one is a group of patients who have no symptoms, no risk factors. Well, you definitely don't want to do CCTA for them because you're giving them radiation and you know it's going to be normal. And the second group is these patients who have a very high risk. You really know they have coronary artery disease. Actually, you don't want to do CCTA for them because you should do a catheter angio for them. And they can simultaneously undergo stenting, angioplasty, and surgery. Other than these two extremes, the whole group in between with variable risk factors can actually benefit from a CCTA because you will be able to triage that group of patients who can avoid an invasive procedure. Okay? So that's what this essentially tries to describe. Coming next to the procedure itself, what would happen? Once you get a form from a physician asking for a CCTA, you would have to first come to the imaging department. Okay? We usually like to look at our patients, have a talk, discuss what drugs they are taking, take some history, find out about hypertension, diabetes, take the blood pressure, pulse, monitor, see whether or not breath holding will be an issue. So we do that pre-screening. We may also require to prescribe some drugs depending upon the blood pressure and the heart rate, which will usually be beta blockers and anxiolytics, and give an appointment for an exam in the near future. Overnight fasting, when the appointment is given, you arrive in the department, you change into the gown, you're taken into the CT room, you sign a consent. Okay, I'll come to the risks. You sign a consent. There's a short period of breath hold training where you'd be told how to hold your breath for the scan. And I'll come to how short that is. ECG leads are connected because obviously the heart is beating, so we want to take the scan with the heart beating, and you need to monitor the heart while the scan happens. So ECG leads are connected. This is the part which is invasive, if you want to call it, and that is minimally invasive, and that is a peripheral IV. So a peripheral IV line is usually selected, a good vein, a good caliber catheter is inserted, IV cath is inserted, through which some drugs might be given, like I said earlier. After that, the iodinated contrast is injected and the scan is performed. We remove the IV and you're good to go home. There's no stay. You're good to resume your routine activities, which may be go back to work. Overall, an in and out would be estimated as 30 to 45 minutes for the screening for this exam. Okay. Coming next to what's the risk and contraindication to this exam. Obviously, one of the concerns is that of radiation burden, but the radiation burden also exists with a catheter angio because that involves X-rays too. This can range between 3 to 25 millisieverts. In numeric terms, you would say 5 millisieverts is what you would expect as a radiation and background radiation in a year. Okay, so 3 millisieverts is the lower end, and we can actually tweak our scans and modify the protocol to keep the radiation burden as low as possible. But in certain scenarios, you may have to go on to higher radiations to maintain the scan quality. Okay. A definite contraindication would be if you have allergy to contrast. So if you have taken iodinated IV contrast in the past and you have had allergic reactions, then we may not be able to do the scan for you. A relative contraindication is that of renal failure. So if the creatinine or serum creatinine is above 2, then the contrast can induce or worsen the renal function, what we call as contrast-induced nephropathy. So that becomes a relative contraindication. However, there can be certain risk-benefit scenarios where we may override this or probably follow it up with a dialysis, okay, to remove the contrast from the circulation. Coming next to results. So once the exam is done, and I wanted to stress upon this, 10 seconds. So the proper scan, because like I said, it's a sophisticated machine which is very fast. The proper scan, a CCTA, is 10 seconds, okay? It's all the paraphernalia around it which takes so much longer. But once the scan starts from the carina to the base of the heart, it's 10 seconds. And that's the duration for which you have to hold your breath so that we don't have motion artifacts. And we usually do a short breath hold training to make sure that those motion artifacts are avoided. We acquire up to 3,500 images, so it's a huge data set which we get. It's in different phases, it's in different parts of the heart cycle. The whole data set is post-processed, and I'll show you some images read by radiologists who are trained and certified to read this. And we generate a report which talks about not just the coronary arteries, but also about other incidental findings. We also save the images for the cardiologist or any referring physician to review. I would say on an average, it would take 24 to 48 hours for a report to be generated. Any stenosis in the coronaries of less than 70% is usually considered insignificant and does not warrant surgical treatment. Okay. What are the limitations of this examination? The limitations, I would say, are not necessarily significant. However, they do exist. A heart rate greater than 70 beats per minute is sometimes a problem, yet we can manage that with IV beta blockers. A heart rhythm which is irregular can be a problem. However, we do retrospective gating. We can manage that by modifying the phases and the reconstructions. Inability to sustain a breath hold for 5 seconds. Now that's going to be a really sick patient, but otherwise almost everyone's going to be able to hold breath for 5 seconds, right? Severe coronary calcifications. And that's usually what we call as a Gadsden scoring. If the Gadsden score is above 400, some say above 600, then it kind of renders the whole exam futile because you will not see the contrast in the vessels outside of the calcium. And very small vessels, so I'm talking about something less than 1.5 millimeters. So if you can imagine 1.5 millimeters, that's a very small vessel. Something that small, obviously we may not be able to assess that in detail and grade the stenosis or talk about its flow dynamics appropriately. If a coronary CT angio is read as negative, then it has a very high predictive value of 99%, which means when the study is normal, it is normal. It's important to understand this because you would have had the same negative result on a cath angio, which is an invasive test, right? With its inherent risks. And it happens 50% of the times in a cath angio. So you're having a negative test with 99% accuracy done non-invasively as an outpatient procedure. CCTA detects clinically significant, which is called as more than 50% stenosis with a very high accuracy. And the test is actually more accurate than stress test, stress echo, stress thallium, stress MR without any stress. Okay? So let's walk you through some images, a lot of slides talking about drab literature. So I'll try and color it up a little. some images, and these are post-reconstruction images, so you should be able to appreciate this is not the real heart, okay? This is a computer-generated image of the heart acquired by the CT scan. So this is the root of the aorta. You can see the coronary arteries coming out, and this is the ventricles, the chambers of the heart. And you can see there's no motion, no blur, no artifacts. The details are just fabulous, right? And this is all because technology has evolved to this point where it can do this. And we all know that. We go and see our superhero movies. You don't even know what's real, what's not nowadays, right? Everything looks real. So the left main, the LAD, the diagonals, circumflex, the obtuse marginal, the RCA, the acute marginal, the sinoatrial branch. We can take out the heart. We can just leave the coronary tree there, see? Subtraction. So it allows you to manipulate your images in great detail. Images can also be rotated, turned around in different planes. We can make negative images which look more like the catheter angio so that it actually suits what a cardiologist wants to review. So we can make images to their taste, to their angles, the choices. Let me show you some pathologies. One of the common findings is myocardial bridging. So if you look here, this is the left anterior descending artery, and this is the part of the artery which is seen here on diastole. But if you see this part of the artery on systole, it's narrow. So you see the difference, it's the same heart. And because we are acquiring the images for a beating heart, we are able to see it in different phases. So that artery actually narrows during systole and it opens during diastole because it is inside the myocardium. It's a normal variant, but many a times it's actually considered pathological, especially if you cannot find anything else wrong with the vessels. Another common finding, anomalous vessels. The coronary arteries are supposed to have standard origins, but they may originate from the wrong side of the aorta or the wrong cusp of the aorta. And they may actually have an abnormal course, which may predispose them to disease or even sudden cardiac attacks, because what we call as a malignant course of the artery. So example here, anomalous origin of the right coronary artery. So if you see here, this RCA is actually originating from the left cusp. The LAD. The LAD is originating from the left cusp. So it should have come off here, but it is coming off here. This is an anomalous origin. A fairly common variant. Reconstructed images showing the RCA here and the LAD here, coming off from the same cusp. Similarly, anomalous origin of the RCA. So you can see the right coronary artery, instead of coming off from this cusp, is coming off closer to the left cusp. These are incidentals, but many a times they can cause sudden cardiac death because the artery gets blocked between the two major vessels, which is the aorta and the pulmonary artery. Coming next to coronary artery plaques. So this is where the test actually is primarily designed, is to see inside the vessel. So for you to look here at this coronary artery, what is a plaque? Plaque is the deposition of lipid, usually fatty content, in the wall of the vessel, right? So if you see here the intima, and you see the yellow stuff here, that's the plaque. And what it does, it narrows the lumen of the vessel. And when the narrowing is significant, then it will block the flow and obviously hamper the supply to the heart beyond it. So this fatty deposits cause arterial narrowing. So, for example, a disease in an artery, but very little disease. You can see this here. You see that small white speck? Minimal disease in the artery. But what we are seeing is inside the vessel. So the wall of the vessel is sharp and clean on this side, all over. But at this point, you see a small calcific focus in the wall of the vessel. So it's able to resolve to sub-millimetric, like I said, 0.04. Very small, very, very, very fine resolution. Another vessel to show you a disease, normal vessel and disease vessel. So you see a plaque here by the side, small calcific specks. And if you can eyeball or guesstimate here, it's about 50% stenosis, right? Coming more to significant disease. This is a normal artery here, and if you go to see the disease on this artery, very significant. Large plaques, small plaques, but all along the length of the vessel, there is significant atherosclerosis. Another slide to show you how different plaques can be. So a normal coronary, a very short but tight stenosis. So a plaque can be really tiny, but it can be tight. Or it can be a very long, insignificant plaque. So they can come in different shapes and sizes. And depending upon how thick and how long they are, the treatment differs. Okay. This is a slide showing you a comparison between the CCTA and the cath angio. So here you can see a soft plaque. So whatever is gray here is called soft plaque, and a calcified plaque is white. Okay. So a soft plaque eccentrically located in this vessel here, and it is causing about 40% stenosis, maybe 50% stenosis. However, if you see the cath angio, it looks fairly okay, right? So CCTA tends to overestimate plaques by a little margin. However, when the plaque is significant, like I said, above 50%, then CCTA is precise. It's only in insignificant or less than 50% stenosis where it tends to overestimate stenosis. This is an image showing you triple vessel disease. So all the arteries can be diseased, right? Like you can see here. Significant calcifications, plaques, stenosis, all vessels, right? And these patients may not have any symptoms. They may present just with atypical chest pain. The test also can evaluate the stents. So a patient who has previously had coronary artery stenting can be seen on CCTA to see the patency of the stent. Okay, so like this image here, it may not resolve this well on this slide, but we can evaluate in-stent stenosis. So the lumen of the stent, if there's plaque inside it, if it is reblocked, can be evaluated. We can also evaluate bypass surgeries. So if there has been a graft in the past to, in this case, for example, the internal mammary artery, the Lima graft, is going on to supply the LAD. So the bypass graft, which is going all the way from the subclavian here to the coronary artery, can be evaluated in its entirety to see whether or not that bypass is patent. Another example of a bypass graft. There are different types. You have reverse saphenous venous grafts. We have internal mammary artery grafts. And they can go from the root of the aorta to the coronary, in between the coronaries. And all of those can be evaluated in very good detail with regards new disease, disease progression, or complete occlusion. So, like I showed you, the spectrum is not just limited to plaque evaluation. It can evaluate congenital anomalies, plaques, aneurysms, before surgeries, bundle branch blocks, because they have a high association with disease, cardiomyopathies, acute coronary syndromes. Let me take a second and talk about it. It's a good triage tool. So, we do it in our emergency rooms. We have these patients with atypical chest pain who have come in. You want to rule out coronary artery disease. However, you want to rule out other diseases too. It could be pulmonary artery. It could be an embolism. It could be an aneurysm in the aorta with a dissection. So there are other differential diagnoses. So to triage these patients, which are atypical for a true coronary artery in the acute setting, CT angio is a great tool. Venography, stent and bypass evaluation. Let me take a slide and move off into lifestyle changes, which is actually probably my last slide. Yes. So you should reduce your risk factors for heart attacks. I would definitely say, going into the new year, if any of you smoke, quit smoking. Tell your friends and family to quit smoking. Doesn't help. Have a great diet of fruits and vegetables. take lots of fibers, avoid sugar. Okay? Walk. 25 minutes of brisk walk, alternate days, that's enough. 25 minutes of brisk walking on alternate days is enough for a healthy heart. Lose weight if you're overweight. And obviously medicines. There are drugs which help and reduce your risk burden. Statins. Statins are under-prescribed drugs. You should take statins, especially if you have high triglycerides. There are some studies which kind of have reduced public interest in statins, but I would say ignore them. Very important, especially in patients who have familial hypertriglyceridemias, statins can be started early. Lower your blood pressure, take the drugs regularly. Aspirin, and there are medicines which reduce blood clots. You should take those, and obviously keep the diabetes in control. These are just 8, 9 things, but within these, you would reduce your percentage or probability of having a cardiac event. More importantly, if any of the risk factors exist, or if you are symptomatic for an atypical chest pain, it's important to approach your physician and get screened, get diagnosis, because without diagnosis, there's no treatment. And CCTA, a coronary CT angiogram, is a very robust screening tool which, when normal, rules out coronary disease. And it's important that you know whether or not you have coronary artery disease when you have symptomology pointing to the same. Because if you don't do that, then it can lead to a catastrophic event and lead to significant morbidity or mortality.
We hope you've learned a lot from this edition of the Doctors Hospital Distinguished Lecture Series. Please join us in the Loudon Conference Center on Dowsville Street every third Thursday for the monthly health talks, where you can feel free to ask your questions. Isn't your health worth it?